It's 4 p.m. Italian time, and as we used to say, it's a great time, literally, to get started with a great project, acronym of graduating residents enhancing active teaching. Of course, we start always with the great image of the Italian pavilion at the Expo Dubai, made by an unbelievable roof of 3 upside-down boats, metaphor of the journey we are all having around the world, metaphorically, and that hopefully will lead us all together in Dubai, since the countdown, of course, started. We are looking forward for being there next February 3-5. Indeed, in Dubai, during the once-in-a-lifetime opportunity of the Expo, we'll have the opportunity of connecting top experts, informing patients during the Winter Dubai meeting, and it is in honor of all the more than 190 countries that we are showing here the 3 pavilions related to the 3 nations in which we will provide simultaneous translation in today. So we will enjoy Russian, English, and Spanish translation. So remember to select the interpretation button you prefer. You can find it indeed in the lower part of the screen, where you can also report indeed a question in whatever language. They will be answered during the live, if not in the following days in written forms. Today we are providing certificates of CME accreditation, so remember to write to the organizing secretary in the following days. We are greatly enjoying the great project that is dedicated indeed to the residents, mainly to the mentorship role with international key figures, and of course also to the audience engagement, thanks to the selected comments that we will enjoy also today. And indeed, we are focusing on the residents because we have had the feeling that with the pandemic, unfortunately, they lost a little bit the chance of joining the stage live. And I really like this image that is actually talking about a concept that is reported also in this interesting paper I suggest you to read. I suspect we'll find the coffin painter in the last one, pointing out the importance of proper training. I deeply thank then the stellar mentors involved in this project, the truly stellar residents selected for giving the talks, and the wonderful experts involved in all the discussions. The focus has been on arterial patients with chronic venous disease and vice versa. This is an interesting publication, again, I suggest you to read, that is pointing out how often we should in reality detect the 2 conditions together. Deeply thank to all the faculty involved so far, and to the one involved today that we will introduce one by one. Deeply thanks to Mehdi for having allowed us to create this unbiased project, calling in first line the residents in particular. Deeply thank once again to the ones I consider family, first of all, and also great colleagues. So now the word goes to Professor Bottini and Professor Chi.
Welcome everybody to the end of this great project for young professionals sharing science with stellar experts from all over the world. Remember, a Spanish speaker can make questions in Spanish, writing them in the question and answer box.
Thank you, Oscar. Willie?
Dear friends and colleagues, good morning, good afternoon, good evening. Thank you for joining us with a great project again. You can make questions in the Q&A box, even in Chinese, for which I will translate. Thank you.
Thank you so much, both, and thank you so much to all the ones who have served as good omen at the very beginning of each and every webinar. And today, of course, we have the grand finale of the great project that is dedicated to compression, and of course, the holy god of compression for all of us is Hugo Parche. No need of introduction, from the University of Vienna. And here is some slides he sent us as a good omen for the day. So he's sending us his greetings. He's pointing out the importance of the topic. He's extending the greetings from the International Compression Club, pointing out that it was founded in 2004 in Vienna, that there are around 200 ordinary international members, 4 industrial members, and the current president is Dr. Giovanni Mosti. And here a nice picture from the beautiful Lucca in Italy in 2010. is pointing out to us that a proper compression is necessary, especially in patients with additional arterial occlusive disease. For this, we deeply thank our dear Professor Parsh, and we get started with the scientific part. As I said before, the project is including always a selected top resident, in this case, Dr. Robert McMurray from the Uniformed Service University of Health Sciences, USUS, Bethesda, truly stellar university institution. And his talk will be about graduated compression indications in peripheral arterial disease. We will then enjoy his three mentors in the person of Professor Rial from the Torrelodones University of Spain, Professor Santiago from Goya Federal University of Brazil, and Professor White, again, from USUS University. And here is his talk, and we will have them live for the question and answers.
Hello, thank you all for allowing me to talk to you all today. Today I will be discussing the controversial topic of the use of compression for patients with chronic venous insufficiency in the setting of patients who also have peripheral arterial disease. The views expressed during this presentation are of my own and do not reflect the opinions of the U.S. government, Department of Defense, or the U.S. Army. I have no conflicts of interest. First, we will discuss the use of compression in the setting of PAD, some misconceptions and international recommendations. Then we will cover chronic venous insufficiency in the setting of concomitant peripheral arterial disease and how often these two diseases are found together in the same patient. Finally, we will discuss the benefits of compression in patients with mixed disease. A common thought is that the use of compression in patients with PAD will further inhibit blood flow to the lower extremities, and we will see later why this concern is not true. So is compression contraindicated in patients with PAD and won't it cause ischemic wounds? In fact, injuries due to compression do and have happened. In this paper by Hobson et al. Evaluating pressure injuries in the SICU, 7.2% of patients in this study were found to develop pressure injuries. Of these, 31% of patients developed pressure injuries due to graduated compression stockings. And interestingly, 42% of patients who developed pressure injuries also had diabetes, which is something that we will look at later. With that said, compression is a viable means of therapy in patients with mixed disease. Currently, European societal guidelines state that compression in the setting of critical limb ischemia is acceptable as long as the systolic ankle pressure is greater than 60 millimeters of mercury, or the toe pressures are greater than 30 millimeters of mercury. Compression therapy can be implemented in patients following peripheral bypass as long as there is no compression on the bypass itself, and compression in the setting of an epifascial bypass should be avoided. Similarly, North American guidelines suggest that compression therapy is okay as long as systolic ankle pressure is greater than 60 millimeters of mercury, or the patient has an ABI of greater than 0.5. Of the 20 different guidelines around the world, there is consensus agreement among the absolute contraindications to compression therapy, but most of the disagreement is in regards to the relative contraindications. The gray area among these clinical practice guidelines seem to be among the use of compression therapy in patients with ABIs between 0.6 and 0.8. In 2019, experts from around the world met in Cortina, Italy, and agreed that the use of compression in patients with arterial disease is an acceptable practice. And I would refer you to this slide if you have further interest on reading about their discussion. And so we come back to the question of whether compression in patients with PAD is contraindicated. And as we've seen, it is not. And in some instances, relative contraindications can actually present as good indications. Next, we will discuss how often chronic venous disease and peripheral arterial disease present as mixed disease in patients. It is estimated that around 23% of adults suffer from some form of chronic venous disease, and up to 20% of adults have some degree of peripheral arterial disease. In the literature, as much as 10 to 18% of lower extremity ulcers have a mixed arterial and venous etiology. In fact, in one study that evaluated patients with known peripheral arterial disease using MRA, 21% of patients showed signs of possible chronic venous insufficiency. Of these patients who suffered from severe chronic venous insufficiency were 1.7 times more likely to have severe PAD. This study concluded that coexisting chronic venous insufficiency was greatly underdiagnosed in patients that present with PAD, as only 18% of patients that were diagnosed with CVI by MRA had a previous diagnosis of venous disease. And the inverse is also true. Patients with venous disease are at least 2 times more likely to suffer from subsequent arterial disease. Now let's discuss how proper compression can be of benefit in patients with mixed disease. In this study by Humphreys et al., using a supervised protocol of properly prescribed compression therapy along with selective revascularization. They achieved good healing rates for patients suffering from lower extremity ulcers for mixed disease. Also, the use of graduated compression stockings in patients with intermittent claudication has not shown to decrease total walking distance or distance before claudication type symptoms have onset. Furthermore, studies demonstrate that oxygen debt within a limb actually decreases after donning appropriate compression. And the more significant the venous disease, the more the benefit that is seen with compression. And in this regard, the more the significant the arterial disease, the more significant the benefit of compression as well. In fact, in this study, 13% of patients who saw the greatest benefits would have been excluded from compression therapy under current guidelines as their ABIs were less than 0.5. Most yet all actually demonstrated that the use of inelastic compression therapy in patients with PAD who presented with mixed ulcers not only improved the venous pump function of the lower extremities, but also improved distal perfusion. And this again was echoed in a paper published as recently as last year, which showed an improvement in toe pressures after donning the compression therapy. And patients also reported improvement of venous symptoms after the use of compression. With all that said, compression in the setting of diabetes has also been evaluated. Wu et al. Performed an assessment of mild compression and evaluated its effects on ABIs, TBIs, and skin perfusion pressure, and found that there was no statistically significant changes in regards to these parameters. Of the patients studied, no adverse events due to compression therapy were seen, and there was a significant benefit in terms of reduction of edema. Rother et al. Took this further in their study published in 2020 and looked at how compression would affect microperfusion in diabetic patients. And again, they found that the compression did not cause a reduction in microperfusion, at least in the sitting and standing positions. There was a decrease in the, with the legs elevated, although this was also seen among the control patients as well. And this topic will further be discussed by another presenter later on. Furthermore, compression has been shown to have a beneficial effect on lower extremity circulation after revascularization. The use of high pressure intermittent pneumatic compression increased cutaneous blood perfusion in the postoperative setting by decreasing postoperative edema. In fact, intermittent pneumatic compression also demonstrated improvements of blood flow and increased ABIs in patients who were not candidates for vascular reconstruction as well. Compression also demonstrated increased walking times compared to a standard walking program. And it also had benefits in wound surface reduction at 12 and 16 weeks as well compared to an exercise program. Intermittent pneumatic compression allowed for a significant reduction in pain and an improvement in quality of life in the patients. And so as you can see, the use of compression has been shown to be safe and beneficial in patients with peripheral arterial disease as long as they have a proper prescription and the appropriate supervision. And the emphasis on the appropriate prescription and supervision can't be emphasized enough. In fact, Canada actually requires not only a provider's prescription, but also appropriate training for those who will be applying the compression therapy prior to its use. So in conclusion, the use of compression therapy for the patients who suffer from chronic venous disease along with peripheral arterial disease is not always contraindicated, and under the right circumstances can be extremely beneficial. Peripheral arterial disease and chronic venous disease are frequently coexisting and often underdiagnosed. And finally, proper compression has been shown to help with reduction of edema, improvement of tissue oxygenation, improved walking performance, and symptom control. Thank you again for having me, and I look forward to the ongoing discussions.
And with this, I deeply congratulate Dr. McMurray and also his mentors, and in particular, Professor White. The nice picture you have seen is from Bethesda. It is a spectacular place, and not just because it's beautiful geographically, but what they do there in terms of medicine is truly outstanding. I think every student should have the chance of visiting them. So truly congratulations to the institutions and to Dr. McMurray and to Professor White. Now we move forward, and as you know, we are going to enjoy 3 mentors who have been related to this talk, starting from Spain, Torrelodones University, Professor Rodrigo Rial, and other institutions in our field. So Rodrigo, if you can unmute yourself and make your comment, this is the time. Rodrigo, I see you there. So if you want, perfect. Unmute yourself and go with your comment.
Hello. I want to express my deepest admiration for Dr. McMurray for having so brilliantly summarized such a complex topic in 8 minutes. Congratulations. compression therapy in peripheral artery disease and in peripheral artery disease concomitant with chronic venous disease has been and continues to be a taboo for many vascular surgeons. So thank you very much for opening our eyes. Lower limb ischemia affects the majority of patients who undergo peripheral bypass surgery. The pathology of this edema is not well understood. The more critical ischemia, the more likely the revascularization edema. And also, it is known that I have never thought that diabetic patients had a limitation in the use of compression therapy, even with neuropathy or diabetic foot injuries. Rather, on the contrary, a good training to the patient and nursing staff contributes to its universal application and therefore to improve outcomes. In my opinion, the most complex decision-making regarding compression therapy is when arterial disease and venous ulcer coexist. Of course, we have already seen that clinical practice guidelines agree to apply compression therapy with ankle brachial index between 0.8, 0.08, and of course lower than the standard pressure. But I wonder, what we do with a venous ulcer with an ankle pressure of 0.5, and we will apply a multi-layer bandage up to 20 millimeters of mercury, or we will directly perform open surgery or endovascular treatment? It is possible. What is your opinion, Robert?
So I think it actually shows that it actually benefits, I think, an actual skin perfusion with mild compression in patients, at least with severe PAD. So I think there's definitely a benefit with inelastic compression with multi-layer in that setting, at least.
Thank you so much, Robert. And now we move forward with another mentor, and thank you so much again, Professor Rial. And this is the time in which we fly to Brazil with Professor Fabricio Santiago and other big experts, in particular on the topic of compression. Here is his comment, and then we will have him live.
Hello, dear colleagues. My name is Fabricio Santiago. I'm a vascular surgeon from Brazil, and I'm here to say to you a few words about graduated compression in peripheral arterial disease. I have no disclosures for this presentation, and I'd like to thank the Viewing Foundation organizing committee for this kind of invitation. So firstly, I'd like to congratulate Dr. McMurray because he has, with the same speed, but at the same time, with the same efficacy as an F-14 Tomcat, he told us everything that we should know about compression on PAD, especially by breaking the misconception that we cannot use compression on PAD since we obey the golden rules. But I'd like to address specifically something about graduated compression, and I'd like to call your attention for these numbers, 18 to 25 millimeters in mercury. So when we look at the publications, most of them regarding the use of compression, graduated compression on peripheral or on PAD, they show that this type of compression, this interface pressure is enough to improve hemodynamics, to minimize edema, and at the same time to improve quality of life questionnaires. So this is the number that we need or we should remember. And when we see also the publications comparing different types of compression on graduated compression, in this publication example given, they were comparing 18 to 21 millimeters versus 23 to 32, and they have obtained the same results, the same outcomes. So this is what we've been using on our day-by-day basis on patients with mixed disease, PAD, and venous chronic disease, with very nice and very good results and with a very good compliance as well. The problem is when we are talking about more complicated disease, just like the mixed ulcerations, I personally think that the publications, they are very clear. We should and we need to use a short stretch compression treatment rather than graduated compression. Although we can use graduated compression, but we have a lot of publications showing that the short stretch compression they give us more hemodynamic effects and in consequence, very good results with compression not greater than 40 millimeters. But the problem is the subjective perspective of giving the compression when using multi-layer bandage. For that, I think we should use, and we could think about using REP devices, although the costs, they are somehow prohibitive. So what about claudication in graduated compression in improving claudication distance? So far, we have some very good results with exercise, also with IPC, but unfortunately, we do not have robust evidence on graduated compression stockings on improving claudication distances. So what about the future? And I think this is probably the present. I think we should look at the progressive compression rather than graduated compression. We do not have publications regarding PAD, but I think this is something that we should take a very good look at. And also we have some incoming new devices, just like the Smart Active Compression stocking or other stockings, where we can combine graduated compression with IPC at the same time with very good results. Of course, this is not related to PAD. And we should take a very good look at the material that we've been using or the industries are using on manufacturing the graduated compressions, the compression stockings. Once we knew that low stretch materials have the possibility of giving us very good hemodynamic results, even in graduated compression. And this is something that we should study. Thank you very much. And let's go to the discussion.
And we deeply thank Professor Santiago, and we now move to the following mentor, and then we will go to question and answer and discussion. So it's my huge pleasure, truly huge, to introduce Professor White from the Uniformed Service University of Health Sciences, one of those doctors we should all admire for what they are doing inside and outside the hospital. They belong indeed to the military force from US. So thank you for all you are doing, Paul, and here is your time for comment.
Thank you, Sergio. I would like to thank Professor Giancini, Professor Bettini, and Professor Chi for inviting Dr. McMurray and myself to participate in the seminar. I really applaud their efforts to encourage the participation of the next generation of vascular specialists in these international exchanges. I want to commend Dr. McMurray for his excellent presentation, and I have a few comments and no slides on his presentation. First, I wanted to reemphasize one of the themes that's been mentioned many times over the previous weeks' webinars and also today, and that's the need to have a high index of suspicion for the presence of combined arterial and venous disease. Aggressive diagnostic and therapeutic strategies should be implemented in all these patients. I think another important point that the use of compression in patients with PAD highlights is the need to carefully tailor treatment to the individual patient. Careful assessment of the degree of PAD and the degree of arterial impairment prior to the initiation of compression is essential. By the same token, in other patients, compression can be initiated as the extent of arterial disease is assessed. I can think of several patients that I've treated in the past whom preoperative compression therapy was essential in reducing edema prior to open surgical revascularization. The point being that careful attention to detail helps ensure the appropriate use of compression in patients with PAD. Lastly, as Dr. McMurray pointed out, educating providers, nurses, therapists, and others is essential to the effective treatment of patients with venous and arterial disease. Thank you again. It's been a real privilege and a pleasure to join you today.
Thank you so much, Paul. And now we get into the world round, where we are inviting top experts from the different continents to provide their comments and eventual questions to the speaker. It is my huge pleasure to introduce Lorena Grillo from the Flebo Latam, a wonderful organization, wonderful meeting, the last one before the pandemic, and hopefully the first one we'll go back to, because it has been a wonderful educational initiative. Lorena, the mic is yours.
Good morning to all. It was a great presentation, and all the comments have been so rich. One of my first things that I want to address is that this event has been great in order to break up the paradigm that compression and PAD are not able to be in the same sentence, and that definitely it's very important to address the use. Regarding mostly to edema being so frequent in patients after arterial revascularization, I think it's crucial to assess some key parameters preoperatively and also to reassess them after surgery. Which doctor do you think are the parameters, or which parameters you suggest that are very important not to be overlooked in making this decision of PAD with compression?
Thank you for your comment, and I would address this to Professor Rial. Rodrigo, would you like to answer to this?
Oh, yes, of course. Hello, Lorena. Thank you very much for your question.
Right.
I think lower limb edema affects the majority of patients who undergo peripheral bypass surgery. The pathophysiology of this edema is not well understood or not fully understood. The more critical ischemia, the more likely revascularization edema. So factors other than local wound healing alone are suggested in the literature to play a role, given the severity and duration of this edema. Hyperemia, precapillary sphincter paralysis, microvascular permeability, repeat pressure associated with inflammations and lymphatic disruptions are likely to facilitate the development of edema. And preventive methods could be lymphatic sparing surgery, very carefully surgery in the groin, intraoperative and antioxidative therapy, and postoperative elevation, and of course, the use of compression stockings are currently the golden standards. I wonder if the preoperative use of compression therapy will have a beneficial effect in reducing postoperative edema, now that we know, as Dr. Marmari said, that it can be applied with caution, with care in situations of advanced ischemia. I know this response to you.
Thank you so much. And now we fly all the way to South Africa, and it will be Professor Bottini to introduce the next expert.
Let me introduce Dr. Laura Redman, brilliant surgeon from the South Africa Vein Lymphatic Society. Between and Lataf, I had the pleasure to work with her in the last year. Laura.
Thank you. Thank you very much. And thank you, Robert, for a very well-researched and presented topic. I think my comment and question actually follows on a little bit from the first one by Loreno. It does seem conclusive that compression is not only unharmful in peripheral arterial disease patients, but actually beneficial. And capillary perfusion is maintained in peripheral arterial disease as much as possible until it's very severe and ankle pressure is below 20. So it's also known that correctly applied compression will act on the superficial veins, improve lymphatic return, and enhances calf pump function. So where do you think the benefit for compression use lies in arterial disease, or where is it acting? And do you think there could be a greater role for it in even more severe arterial disease than is currently accepted if there's no microcirculatory disease?
Robert, unmute yourself.
So I definitely more are obviously required for the patients that are in severe PAD. When you use the studies that have been done, I feel like they kind of have arbitrary cutoffs at 40, 60 millimeters of mercury. We really need to start looking at the microperfusion down patients that have very minimal peripheral perfusion down to the lower extremities, and see what compression really does to those patients, as well as show a true benefit in patients, maybe with all PAD patients, and see if there's a benefit in that as well. In terms of where or how it's improving things, I definitely think that instead of the concomitant disease, that it is helping with reducing edema in the setting of perfusion edema, but not only the peripheral venous disease as well. But in terms of how it's truly improving arterial disease, I would probably defer that to the further experts on the panel.
And I can take on that. I think it is a very brilliant question, Laura, that you're bringing up. We did some investigation in the University of Ferrara showing how if you go with higher CIEP and a lower ABI, you have the best benefit. And we have done this by near-infrared retroscopy. So very probably ABI, in my opinion, is not really the only thing we want to consider in this, but it's far more complex. And of course, we don't want to promote compression without proper awareness of the condition and with proper expertise. So of course, expert sense with proper parameters that very probably are not just ABI. But it is interesting to notice how, if I remember correctly, around 13% of our patients who benefited the most in terms of clinical results were the ones with the lower ABI. So food for thought for future discussion, and perfect question. Thank you so much. And now we fly all the way to Mexico. Thanks to Willie, who will introduce us to the next expert.
Yeah, next we have Dr. Javier Serrat from, who's a leading figure from the Mexican Academy of Fluid Lymphology and certainly a great friend of the VUN Foundation. Javier.
And I see we have connection issues with him, so I will take it from here and we'll take the chance to torture my friend Fabricio, since we enjoy a very good friendship and passion for compression. So Fabricio, we have seen data about different results with compression, of course, in standing patients rather than lying patients, particularly when we're talking about arterial patients. And here in Italy, we tend to prescribe compression also when they are, of course, in the lying down position after the procedures. So could you comment a little bit more about the use of compression in venous and arterial patients in lying down rather than standing up positions?
But when you mean procedures, you mean arterial procedures or venous procedures?
Venous procedures.
Okay, so after performing the procedure.
Yes.
So here we often use the graduated compression after procedures with low stretching materials. We have some graduated compression stockings with less stretching materials, so giving us more dynamic effects since the patient walks. So this is how we prefer to use after the patient is standing. If it's for thromboprophylaxis, this is we use the common ones.
And since we have
I don't know if I answered your question.
Partly yes, but it is a very complex, I think, topic for which I will ask also Joe to jump on board in the discussion in terms of standing versus lying down patients, when we have also an arterial component and they are also venous patients. So do you have some insights on this, Joe, you'd like to share?
Yes, I think that the key issue here with all of these patients all of the time is the balance between perfusion pressure and compression pressure, and also the type of compression. And I think that it's very, very important after the non-invasive procedures to use compression. And if there is coexisting PAD, then I strongly recommend any form of inelastic compression. And I think that one of the problems that you have, and I think this goes to the question, is that we know that people with severe PAD, when they're lying down or their leg is elevated, that lowers that perfusion pressure sometime to a critical level, and they become symptomatic. So that in patients with severe PAD who have elastic compression, it can be hazardous having them lying down versus standing up. So that and I must say that after many, many years, decades of practice in this area, and my close association with Hugo, I have really, really become a fan of doing everything possible to put as many of these people as possible in some form of non-elastic compression. Inelastic compression. And sometimes, you know, there's, as Hugo always taught me, there's many roads to Rome. And sometimes what that means is that you may even under certain circumstances use an elastic bandage and then put another elastic bandage over it. And then the net result of that, it becomes more inelastic than the elastic bandage by itself.
And of course, this is totally true. At the same time, Joe, I'm always in concern with the data, for example, published by PROTS, with showing that 10% of the health professionals were really able to apply the pressure they wanted by bandaging. So we will enjoy, I think, also Attilio Cavizzi later on talk on this, because it is really quite complex argument. So let's move now to the final part of the word round. We fly all the way to Russia. It is my pleasure to introduce Professor Igor Zarutokin, a dear friend, a great expert who is traveling by car. So he just sent me his video.
Hi to everyone. I have two questions, both to Dr. McMurray. The first one is, do you see any difference between the possible mechanism of action of compression in patients with just a chronic venous disease and those who have concomitant peripheral arterial disease? And the second one, if a systolic arterial pressure in the big toe is improved by compression, as Markus Sturman and his colleagues confirmed in their study, then should a compression be used in, let's say, mild peripheral arterial disease without any signs, any symptoms of chronic venous disease? Thank you.
Robert, would you like to make some comment on this?
So, with regards to the second question, I think that's a very fascinating thought in terms of what to do in patients that don't have the edema that have shown improvements of perfusion pressures in the setting of compression. I don't know personally what I would suggest in terms of that, but I do think it is kind of a fascinating area to look into the future with basically managing compression and arterial disease with no evidence of chronic venous disease. I think in the setting of patients with both venous disease and PAD, I think most of the big benefits have been shown with concomitant ulcers with the amount of decreasing edema, which has really shown improved healing rates with patients that probably initially don't have a good enough blood flow to heal those ulcers by themselves. Getting edema out of the region really benefits with those patients with compression.
Thank you so much. Paul, would you like to jump in for an extra comment on this? Paul?
I think I agree with what Dr. McMurray said. I think it's a topic that probably can undergo further investigation. I think with most patients with mild PAD, the standard sort of treatments of risk factor reduction, medical therapy with a statin, dual antiplatelet therapy, those sorts of things are probably going to have the most benefit.
Thank you so much. And now we go toward the final part of this first part, that is indeed engaging the audience. So let's have a look at the question that is coming from Gabriella Cincilla. She is asking which type of exercise is most recommended in patients with PAD? Do you recommend to make exercise with or without compression? Bob, would you like to take this?
So most of the data that I responded to, or at least presented, was just standard exercise walking programs. So getting out, walking until patients have symptoms, stopping, recovering, and walking again. I think that's kind of the standard with what we've been doing. But I do think that there's improvement, or at least benefit, in doing both in terms of walking plus compression as well.
I see we have Joe jumping in.
Yes, I just want to add something to that. And first of all, going back to the question, I think it's very, very important. All of my experience using the Pico press in short and long stretch compression, the incredible increase in standing stiffness index between lying, standing, and walking with short stretch compression, and that includes Velcro, by the way. The pulsatile increases actually cause the valves, incompetent valves, to open and close. It simulates valvular opening and closing, and the amount of blood that flies out of the leg, velocity, is really incredible with exercise and so forth. And we need more studies like this. And as Dr. Chi is telling us about too, is that we need to find out an accurate dose of the compression we're using and the hemodynamic effect of that dose has been pointed out already by some others.
Thank you so much, Joe. Fabrizio, I know you have some comments you want to add?
I'd like to make a question to Dr. Robert and consequently to Dr. White. So I'm part of two residency programs here, and we have a lot of difficulty to break the paradigm and the misconception that we can use compression on PAD. I would like to ask you if you have the same problem in your service, even with the staff members. So if you have the same problem in your service, and what about in US? Because this is something terrible, and nobody can accept the concept that we can use it.
I'll comment just as from my training perspective, kind of going in and out of different programs. I've definitely seen the old school thought of kind of it being taboo, especially in the setting of revascularization. People really are concerned that compressing, the revascularized area is just going to inhibit the blood flow and cause, lack of healing from the wounds. So I've still seen that. I have not seen that here is so much on my home institution. I've actually seen probably the opposite. We've had a recent patient that had arterial procedure, which, with post-thrombotic syndrome that we've been compressing and has actually been doing well. So.
Thank you, Paul.
Dr. White, could he?
Yeah, I agree. I think it's I think there's a difficult problem in getting people to realize that compression, when appropriately used, is beneficial in patients with PAD. And there is a misconception that it's absolutely contraindicated. I think that often that's the result of seeing the misapplication of compression. We still run into people who are applying too much compression. Oftentimes I see it with ACE wraps, where you have a elastic bandage, and the way that those tend to roll up and things like that, you often see those misapplied by trainees or inexperienced practitioners, and end up with a bad soft tissue injury from inappropriate use of compression. And that scares people away, I think, in some degree. So I think we do have our work cut out as far as educating trainees both in the appropriate use and that it's beneficial, but it has to be done right.
Totally agree. Thank you.
We have Joe hands up.
I'm sorry, but I've had a lot of experience with this, and I would echo what the others said. I am shocked, even in my own institution where I've been using short stretch compression since the 1980s. I see patients all the time after severe ischemia, and they have a revascularization procedure with a FEMPOP bypass, and they have revascularization edema, and they come to me because the wound is bulging and engorged, and I take off the ACE bandage. And I've tried to teach them not to put these ACE bandages on those patients. It just doesn't work. And putting Velcro devices on them, and of course, it's nice if you can get them, but the Velcro devices are ideal. And I can't tell you the number of patients that I have helped with revascularization edema using this approach. And the thing is that you put the Velcro on, measure the pressure. You can use the Juzo measurement. It's simple to measure the pressure. And then if the patient has any discomfort, they loosen it. And if they have good results, it's going to start to fall down because the leg is going to get smaller, and then you can tighten it. But the use of Velcro and revascularization edema needs to be explored with good studies, because it's amazing. It's amazing the resistance. And I'm talking about my attendings and in my own vascular surgery division, how hard it has been to get them to get away from putting that ACE bandage on.
Thank you so much, Joe. We go back for a second since we have still 2 minutes to the audience. Pablo Diana Bunja is asking us in Spanish, so let me translate. Good morning. I'd like to ask you for how long we should use compression, and we should treat first arterial venous disease. For the sake of time, I will just reply saying that you might also ask if we shouldn't treat them together rather than staging the two procedures, considering we have very minimally invasive venous treatment possible, and considering the risk of developing edema in the recurrences. I would keep it going. Of course, the important thing at that point is the patient's comfort, and I think we'll greatly enjoy the talk of Attilio that will touch also the patient's tolerability of proper compression. I will just make a final comment on the exercise because we are really fond of that too at the University of Ferrara. We have done some studies showing the impact on the perceived exertion by objective scales like the Borg scale, and there is a significant improvement that is dose dependent. So of course we need proper prescription, but proper compression can help managing edema and consequently also symptoms during the practice of sport. It's exactly 4:45 in Italy, so we are perfectly on time to close this first session, but not before deeply thanking the stellar faculty involved so far and congratulating Robert, who has been the last, but not for sure, for quality of the 5 residents we engaged. So we really look forward for having you with us again in this group of friends and top colleagues. Now we move forward indeed toward the end, and as per tradition, we have an honorary lecture, and a great honorary name, of course, is the one of Dr. Attilio Cavezzi, a neighbor of mine in Italy, a dear friend and a mentor as well. He will be talking about graduated compression innovations in peripheral arterial disease. Here is his talk, and then we will have him live with us.
Thanks, Sergio, for your kind invitation. My role is to speak about graduated compression innovation for peripheral arterial disease. This is my disclosure slide. So we know that during the treatment of chronic venous disease, we may have some comorbidities such as diabetes mellitus and peripheral arterial obliterating disease, which have been considered a kind of possible contraindication when using medical compression stockings. This is a very interesting document, an international consensus document from a lot of very high-level experts concerning the recommendations on the possible contraindication and risk of compression. Basically, these experts highlighted that there is a possible risk of complication in case of severe peripheral arterial obliterating disease and severe microangiopathy in diabetic patients. And so some specific precautions were advised in diabetes and let's say when using medical compression stocking in peripheral arterial disease with, let's say, an ABPI below 0.9. But when we have a much worse condition, such as ABPI below 0.5, or even more when the systolic ankle pressure is below 60 millimeters of mercury, then probably compression stocking could be considered, or compression in general could be considered contraindicated. So this study in 2012 highlighted quite good outcomes applying compression at mild level, 18-25 millimeters of mercury, in patients with diabetes and edema. From the point of the edema, it was good, but especially there was no relevant side effects in these patients, and even the ABPI improved at 2 weeks, which was not true anyway at 3 and 4 weeks. This is another study where they applied 18 to 21 millimeters of mercury medical compression stockings in patients with peripheral arterial disease. And as you can see here, wearing the stockings led to an increase of, let's say, systolic arterial pressure in the big toe. And also, both arterial and chronic venous insufficiency symptoms improved. This is another study from a French group, which was published 2 years ago in VASA, and they assessed the possible side effects, and they found basically no specific problem in terms of tolerance in these patients, and they had no worsening of their arterial and venous symptoms, so reporting no adverse effects. Now let's come to a very interesting study which was published more recently, last year, in patients with chronic venous disease and peripheral arterial obliterating disease or diabetes mellitus. This was a controlled trial investigating the safety of medical compression stockings in these patients. 94 study participants were enrolled. There was a healthy subject control group, patients with arterial disease and patients with diabetes mellitus type 2. All patients had edema, and they applied 2 different kinds of stockings, 18 to 21 or 23 to 32 millimeter of mercury, specially designed medical compression stockings for these patients. The primary endpoint was to assess the safety of these stockings. The secondary endpoint was to assess the comfort of wearing these stockings. In this table, basically what you can see is that in terms of safety, the changes in the microcirculation were not relevant. So that means that both class 1 and class 2 stocking, the specific stocking, had a stable microcirculation in physiological positions in terms of oxygen saturation. On the contrary, there was some worsening when lifting, when elevating the legs. That means that both in healthy controls and in these arteriopathic patients, lifting the limbs led to some worsening of oxygen saturation. This was true also with blood flow perfusion. So let's say that the study demonstrated from the safety point of view that the specific medical compression stockings did not lead to any specific changes in the oxygen saturation and blood flow perfusion beyond the risk of the elevated limb position. From the secondary endpoint of view, the wearing comfort was very high, as you can see from the Likert type scale. The vast majority of the patients showed let's say, a high wearing comfort. So the conclusion of this study was that in this first study, which evaluated the medical compression stocking specific device into different groups of arteriopathic and diabetes patients, basically resulted in the absence of relevant side effects, both with class 1 and with class 2. The microcirculation was stable beyond the possible deterioration when the leg was elevated. These results were somehow anticipated even in, let's say, mixed venous ulcer in the presence of concomitant arterial occlusive disease, where in this study with Giovanni Mostri, Professor Patch, we could highlight how the treatment of the recalcitrant leg ulcer was improved with modified compression, even in presence of arteriopathy. This is a very recent study where, again, diabetic patients showed basically no deterioration, if not an improvement, when using compression, tailored compression, let's say, and foam sclerotherapy to treat their venous or mixed leg ulcers. So the usage of compression, again, did not result in any specific deterioration, if not in an improvement of the final outcomes. This is an elegant review on the compression used in arterial venous leg ulcers, and they somehow promoted the use of a compression with the pressure between 20 and 30 millimeters of mercury to improve the healing of the mixed arterial venous lymphatic ulcer. So, to make it short, adequate compression therapy, and to go to the end, adequate compression therapy has a contrasting degenerative tissue changes in arteriopathy, which means that adequate compression therapy can increase rather than decrease arterial microcirculation perfusing, so increase at the arteriovenous gradient, can reduce, of course, edema, which means that we can reduce by means of compression the compression on the capillaries and the distance between nutritional capillaries and the tissue cells, even when using low pressure. And if we look at all these, let's say, different pro-inflammatory mediators, we see that compression can reduce the expression of these mediators, thus enhancing the condition, the clinical condition. Sincerely thanks to everybody.
And it is us deeply thanking Attilio for the honorary lecture. We will have him live in a second after the two honorary comments. And of course, for the honorary comments, we thought about the two pillars who are making everything possible in Bwin Foundation. So here is Professor Bottini comment, then we will have Willy, and then we will enjoy Attilio live.
Let me express my gratitude to all of you for participating in this educational proposal. Looking at your faces, I can only see people capable of transforming the scientific and educational reality in the world. In these sentences, we will think about the relevant points of compression in chronic venous disease of the lower limb. An interesting Chinese study shows the poor existing knowledge. This generates a negative attitude in the population, causing inappropriate behavior in 30% of patients. Even more serious is that more than 80% of the indication for compression stocking and bandages are not prescribed by a specialist, which generate low compliance to treatment due to the lack of the inadequate explanation to patients. This work by Sergio shows the need to measure the interface pressure properly, avoiding comparing orange with apples. This is evident in this other study that reported inappropriate use in 1 out of 3 patients and inadequate size in 25% of patients. Another interesting study shows that applying the same surface pressure, the pressure in the subcutaneous fat increased significantly, being 2 times higher in standard people. Intermittent pneumatic compression as antithrombotic prophylaxis in trauma patients was used in 20% of the cases, and half did not receive compression therapy in postoperative patients. Another study shows how adequate compression can improve the hemodynamic of venous return, reduce endothelial inflammation, and shear stress of capillary wall, due to the increase in speed that avoid the distal venous stasis of the limbs. Finally, in this other study that compares the fibrinolytic activity of the wall and intermittent pneumatic compression in healthy individuals or patients with post-thrombotic disease, that it should be continued to obtain more representative samples to reinforce this argument. There must be a balance between benefit and risk, especially in those patients with associated arteriopathy where the experience of the professional plays an important role. Thank you.
With this, we deeply thank Oscar, and we go the way to California for Willie comment. Willie, would you like to share your screen?
Yes, thank you. Well, thank you all for participating in the great project. Do not have any disclosure related to my comments. Over the last 8 minutes, Dr. Kavita gave us a very nice overview about compression and PAD use, which I'm not going to repeat that. But back in 2006, ICC published a guideline in terms of the ideal sensor. It has 18 criteria, which you all could read about. And currently, there's no such sensor that satisfy all 18 criteria. But I want to start with something that we're familiar with, which is a pneumatic sensor. Now, Joe had already talked about the Juzo device, but there are obviously other devices that was out before it. We have the Kikuhaimi, the Sega tester, and then the thing that we're very familiar with, which is the Pico Press, using all pneumatic physiology, infusing about 1 to 2 cc's of air into the bladder, and any variation in pressure coming from the electronic registry is going to be deemed as our interface pressure. Now, the second type of sensor that's out in use that we're very familiar with is the piezoresistor sensor, which requires membrane deformation. As we're putting compression product on, we're actually deforming the membrane. It's actually a very simple construct with 2 PET material, silver ink, a carbon ink, and a spacer in between. And the underlying physics of a piezoresistor sensor is that when electricity is applied to the sensor, you have the highest resistance. And any manipulation of the sensor, and that includes membrane deformation, the resistance drops, and then that registers as increased pressure. Now, based on my group's work, we actually have studied the piezoresist sensor in terms of its front and back surfaces and compare with PicoPress. Although you could see that the mean of the two different devices are actually overlap with an insignificant p-value, but if you look at the individual pressure ranges, that the standard deviation actually varies widely. Now, what about any new type of sensor? Certainly we have the fabric sensor, but something that's out in the field would be our capacitor sensor, which involves basically microfluid, and that's actually ionic fluid, and that could either be in the form of fluid or film. Now, is interface pressure or pressure important in terms of compression therapy? Absolutely yes. But I believe that more importantly is compliance, because without the patient actually use the product, we're not really going anywhere with the healing. Now, based on Raju's publication, we know that compliance in compression stockings is less than 50%. And even looking at the SOX trial, an overall about 44.4% of patients that do not use regular compression in over 3 days per week. Again, this is based on a trial basis. All right. Now, are there anything that we have available that can measure pressure? ThermoTrack is a device that was actually published by Jean-François Wu's group, published in 2018, looking at a little tiny temperature registering device that came from the food industry, and it's actually embedded in the seam of the compression stocking. And basically, you could measure whether or not patient is using it. So my take-home points based on this excellent lecture by Dr. Kavitsi is that interface pressure is important, but measuring tools have significant variabilities in terms of the pressure range and the standard deviation. Do we really care about the absolute pressure versus pressure ranges? And based on what Joe and Fabrizio had talked about, would be our resting pressure and working pressure ranges. That actually would be more, I would say, interesting to academics. And certainly compliance is the key to healing. Thank you.
Thank you so much, Willie and Oscar. Attilio, welcome live. Can you hear us?
Yeah.
Yes, here we are. So would you like to make a comment to what Willie just pointed out?
About Willie, yes, I can only agree on the fact that we should know exactly the rest pressure and the work pressure. I completely agree. And we are looking for maybe an optimal device to measure all this stuff. So I may agree on that.
Perfect. So now we go to the word round, and we start from Crane. It is my huge honor and pleasure to introduce Larissa Cernuka, a brilliant figure in our vascular ward. She's having connection issues, so I will take this chance to make a question to you, Attilio. We know that there is basically no difference, correct me if I'm wrong, in below versus above knee when we are talking about post-thrombotic syndrome. But when we are talking about these patients, would you see when there is PAD involved? I mean, a difference, of course, up to my knowledge, there is no data, but we know that there could be an effect on the stabilization, for example, of the joints thanks to compression. So even if I don't have data, I usually prefer to prescribe above knee when I see that there are also postural defects, considering these might be older than the usual patients of ours. Do you see some potential interest in this or not for future research?
Well, that's an interesting issue because somehow we may have patients who have also most of the peripheral arterial obliterating disease are elderly, so they may have some joint problems. And with the below knee stocking, you may induce some knee edema, what we see from the clinical practice. So it's a good issue to think about the thigh stocking instead of the below knee stocking. What counts, of course, is the level of the compression at the ankle level. So anyway, it could be an option to make a study, let's say, because we have no data as you.
Thank you so much. Joe, would you like to make some comment on this?
Yes, I would. I think that that's a brilliant and forward-thinking suggestion because there are many issues with patients, as already mentioned, and I really think we need to take a look at this. The problem is that it's very difficult to apply and remove and also fit people because a lot of times they have very large thighs, and that's an impediment. But this needs to be looked into more carefully. And also, there's no reason why we have to get away from this concept of graduated compression alone. We'll discuss that at the end in what Giovanni has taught us and others. And that principle probably would be very well suited to use in this type of a hybrid longer leg stocking.
Thank you so much. And now we fly all the way to Egypt. A dear friend, I would have liked to introduce him, but it will be Oscar doing that. Oscar? Do we have Oscar with us? Unmute yourself.
Sorry. Now we travel to Africa to present Professor Hussein, President of the African Association of Vascular Surgery, founder of the Vascular Society of Egypt. Professor Hussein?
Yes, good afternoon, and it's really a great initiative. Compliments to you, Oscar, and Sergio, and Willie. But very quickly, in 1 minute, I'd like to ask one question. We have traditionally known post-revascularization of peripheral arterial circulation ischemic patients that when they develop leg and foot edema due to reperfusion syndrome, that compression therapy might help. We have known that over the years. But my question is, which is the best candidate patient among those suffering from PAOD and having CVI as well? Are we talking predominantly about those 2A or 2B patients, ischemia patients, with ABIs less than 0.8 and more than 0.5? And which is the one recommended objective test to measure by sensors the tolerance of the microcirculation and foot perfusion? Thank you.
Well, that's a complicated question, let's say, but on one side, I would say that once you perform a revascularization, you expect the limb improves from the arterial perfusion. So somehow, even if the index is around 0.5, 0.6, is still a good indication to compress the limb just after the revascularization. Also because we should remember that sometimes we injure the lymphatic vessels during the operation, which is another point to compress, because edema is always a question of lymphatic, or because injured or because overwhelmed, let's say, on one side. And as to the let's say, the way to assess the perfusion, we know that the near infrared spectroscopy or the pressure of the toe oxygenation are good, but we all know that somehow they're not so fully available everywhere. So still, Doppler is interesting. I would say one important thing. I take 30 seconds more, Sergio, sorry. When I was very young, it was in the 86, 88, we performed a very long study on taxi drivers, and we found much more easily their peripheral arterial obliterating disease using the post-exercise ankle brachial index, which is much more sensitive to detect this arterial disease. So this is another issue which we could take into consideration, not just the basal index, but the post-exercise, because that you would highlight much more easily and much more anticipated the issue of an arterial disease. This is something we should take into consideration during the studies.
Thank you so much, Tilly, and thank you so much to Professor Hussein. I'm happy to share with the colleagues, Professor White and Dr. McMurray, that also Professor Hussein has enjoyed presence and affiliations with the Uniform Services of USUS. So it's a very, very beautiful group, as we all know, and we are really happy to have them with us today. Let's go on flying around the world. I wish it was me introducing our Queen Pauline, but it will be Willie. I will just say that she's the perfect presence for a project dedicated to residents. She has been teaching phlebology splendidly in a lot of courses for the new generations in Canada and worldwide. Willie?
Well, I don't think Pauline needs any introduction from us. She's obviously a leading figure, not in Canada, but also in the world. A very special friend to the VUM Foundation. Pauline?
Thank you very much, Sergio and Willie. My question is for Attilio, and congratulations first, Attilio, for opening my eyes on this, I would say, innovative concept. My question is, because there's a certain percentage of patients with combined CVI and PAD, would a different approach to graduated compression using progressive compression mentioned by Dr. Santiago that applies maximal pressure over the calf instead of over the ankle be superior with respect to improvement of pain and lower leg symptoms on patients without edema?
Well, okay, that's a good question, of course, Pauline. I think we would need, let's say, a randomized control study to answer this question properly, of course. Progressive compression is interesting because you focus on the calf, which is extremely important, for example, especially in post-thrombotic syndrome, where you have a lot of issues with popliteal vein and whatever around the calf. In peripheral arterial disease, of course, not to have a high pressure at the ankle is another interesting issue. That's why to tailor the proper stocking and also the way of knitting the stocking is important. So I cannot answer you properly. It's a matter of the tissue that you use, the fabric that you use, the wearing, the knitting, and so on. So it's something that we should take into consideration for the future.
Thank you, Attilio.
You're welcome.
And we move forward, flying all the way to Thailand. It's my deep honor and pleasure to introduce a dear friend, and I look forward for collaborations also among our institutions from the university. It is Professor Nuttaut from Idol University. Nuttaut? Here we are.
Yes, thank you, Sergio. I have one question for Professor Kawesi. In diabetic patient, medial calcification cause incompressible artery and then make the ABI measurement is higher than normal. In this patient, do we need to measure toe pressure or toe pressure Becquerel index instead of measuring ABI? Thank you very much.
Well, that's a very classical issue that we may raise in diabetic patients. That's why we should prefer, whenever possible, the two measurements on one side. Again, I would reinforce the issue of the post-exercise ankle brachial index. This is another interesting possibility we have. And somehow I prefer, in case of compression stocking, to rely on the absolute systolic pressure more than the anterior brachial index, especially in these patients. But we know about the issues of neuropathy and about the microcirculation and so on and so on. So we know that probably toe measurement would be better in these patients at the end. But again, it's not so easy in most clinics or in most offices. That's why we should tailor the compression to the patients we have. And that's why doctors exist, let's say.
Thank you so much, Professor Nuttaut and Attilio. I would take this time for an open question to the panel, because Pauline really triggered an interesting one. I think we know from progressive compression, up to my knowledge, that we have an improvement in the ejection fraction, basically. And we know that with a dose effect, they demonstrated in electromyography that the triceps surae is having less fatigue with more pressure rather than less. Now I'm a little bit confused if we should work more on the anti-edema effect, so we wouldn't need that much pressure for these patients, or on the hemodynamic effect for reducing the overload, or maybe both, or maybe changing the features of the stockings for different resting rather than working pressure. Of course, I would start with everyone apart Joe, who will be the final truth for the answer. So if there is somebody who wants to jump in.
I mean, if you want me to tell something, that we know that most studies were focusing on edema. So that was the aim of the stocking and the aim of the study, let's say. So if we talk about edematous patients, then we know that we need this kind of approach. When you focus, as you properly told, on the claudication, for example, on the muscle fatigue, that could be another, let's say, target for another kind of stocking, probably. But so far, I would see stockings in edema, especially.
Thank you, Attilio. Any other comment from the panel? Fabricio, I see you're moving, or yes, Fabricio.
Oh yes, the problem is we also have the misconception that arterial patients we need to improve their microcirculation. Not only that, we need to increase their resistance to lactic acid. So when you talked about fatigue, Eduardo Damata has some very nice results here using REP devices on claudication patients. So increasing their resistance, their claudication distance using REP devices, compressing more the upper leg rather than the ankle. So probably this is caused by increasing the resistance of the acid lactic. So this is something that we use on patients when we are trying to make them to exercise themselves. Okay.
Thank you,
I
Fabricio.
think that should be a reasoning.
Thank you. We have a question from the audience, then we will move with Joe, and then we will close. So it's Eduardo Valifuoco. Attilio, if you want to have a look at that, it is, what do you think about the use of mechanical progressive peristaltic compression of legs to reduce edema and improve arterial blood flow rather than elastic bandages or stockings? The obtained good results could be maintained by non-elastic bandage. There is a lot to discuss over here.
Well, I mean, we are talking probably about intermittent pneumatic compression. So that means that it's a very interesting technology. We know that probably not every single patient has the possibility to have this device at home or applied, let's say, in an office, in a medical office or whatever. So it's interesting. There is a lot of literature about that. So I would absolutely accept it. Stocking is more practical from this point of view if you have to reduce edema. The issue of inelastic material, okay, I understand it, because we should prefer inelastic material or low elasticity material. So I think that somehow the latest models they provided on the market somehow listen to our need of proper knitting and the high work pressure and low rest pressure. So again, intermittent pneumatic compression is interesting, but stockings are more practical, say.
Thank you. And also more validated, because up to my knowledge, we don't have agreement in the guidelines about standard protocols. Joe, would you like to give us the finale and then we move forward? Just for this comment then.
Well, I think that I can't believe how much I've learned today. From all of you, from all over the world. I came in here with all of my preconceived ideas and singing this song that I sing all the time, short stretch compression, Velcro compression, and so forth. I can't tell you how much I have learned from all of you around the world because of the fact that there are different situations in different countries and different products available. And all of the comments that were just made, I think, are extremely valuable. And we need to push forward. The one comment on this that I think is two things are really key. Number one is the industry has been very resistant to the progressive concept. They have yet to produce a good stocking, progressive stockings other than for special studies. And that resistance based on the dollar is a frustrating thing. And the second thing is, and I would just throw this out, prevent that awful trial that was in the New England Journal that sort of put the kibosh on using pneumatic compression in addition to low molecular weight heparin for prophylaxis. It was totally blown away by Cyril Lobostov's excellent super IPC study, plus the fact that every patient that gets an anesthetic needs pneumatic compression because of all the changes that go on during surgery. All of that having been said, one of the most important issues that needs to be further put forth, as all of you have said, is the multiple uses of IPC in patients with PAD.
Thank you so much, Joe, and thank you so much, Attilio, and all the top experts involved in this round. We are going toward the great grand finale, not before giving a final honorary quick talk from a very important colleague from China, Professor Lianrui Guo, Deputy Director of the Vascular Surgery Department of the Xuanhu Hospital, Capital Medical University. We will enjoy his talk on graduated compression and mixed ulcers, and then we will have Joe for a final comment live with him.
compression therapy of venous leg ulcers in PAD patients. Venous leg ulcers is quite common in clinical practice, and compression therapy is recommended from a lot of guidelines to treat the venous leg ulcer patients because it can increase the healing rate and decrease the risk of ulcer recurrence. About 15 to 30% of patients with venous leg ulcers have concomitant arterial disease. Compression is able to improve venous hemodynamics and reduce edema, but on the other hand, it could potentially restrict the arterial blood flow. Can the venous leg ulcer patients with PAD be treated with compression therapy? In the clinical practice, the compression therapy is recommended for patients with mixed ulcers when the ABI is more than 0.8, but when the ABI is less than 0.8, it's usually considered an exclusion criteria. This also measured some mixed ulcer patients measure the pier wound and distal part microcirculation and found that compression therapy in mixed ulcers can increase the venous output and arterial perfusion. And found if the patient with mixed ulcers presenting a systolic ankle pressure more than 60 and toe pressure more than 30 showed a significant improvement of reduced venous pumping function when inelastic bandages with a pressure up to 40 are applied. Another author did another study. This is a prospective analysis of 94 consecutive patients, 44 with diabetes, 45 with PAD, and 5 healthy, undergoing medical compression therapy. Measure the macrocirculation in different positions at different sites. And here shows the results. He found no compression-related adverse events occurred. An evaluation of the macrocirculation parameters at different locations in different positions revealed no tendency for reduced macrocirculation in both groups. So he concluded that mild compression by specifically designed MCS may be effectively and safely used in patients with PAD disease and diabetes and like edema patients. But for the CRI patients, the treatment should begin from the revascularization and restore the blood flow, the arterial blood flow first. The prevalence of PAD in venous leg ulcers should be paid attention. Compression therapy in mixed ulcers can increase the venous outflow and arterial perfusion, but more data are needed for CRI patients. Thank you for your attention.
And it is us deeply thanking Professor Guo for the honor, and indeed Professor Guo will have the honor of a comment and question directly from Professor Caprini. Joe?
Yes, thank you very much. I think that that was a very, very nice summary of a very complex topic, and I certainly agree with everything that you have put forth, and we need to do more work. I would just like to ask, what is the availability of Velcro and other compression wraps in China?
In our hospital, not all the available commercial available stockings. It's rare. It's only homemade and a little from the abroad. We do not have this Medivin. We do not have this. It's not available in our hospital. So in the mixed ulcers, we normally use inelastic bandage.
Yeah, that's too bad. I think that with the Chinese ingenuity, you need to start a company over there and start to make those things and make them available. I've never seen anything more valuable to the patients, but I know that the cost has been a real problem. But I'd also like to congratulate the Chinese in general for all of the wonderful things that you've done for us in terms of a risk assessment.
Thank you so much, Joe, and thank you so much, Professor Guo. We are going to the end. I know that Fabricio would like to take one last question, and it's not in the program.
No, actually, it's not a question. It's about the comment of Dr. Sermsa. So in the lack of the presence of the two cuff, something that we've been using. This is not validated. It's more likely to have a duplex ultrasound in our service rather than the Q-TUF. So we should, here we select the best arterial with less calcinosis to measure the systolic peak, rather than using the two-cuff that we don't have it, but we have the duplex ultrasound device. So we select the arteria and then we measure the systolic peak.
Any comment on this? No? Okay, so thank you for your contribution, Fabricia. And now it's finally time to conclude with what would have been the usual social moment, but we will have just to do that online. You might notice that I'm properly dressed today with a t-shirt that means so much to us, because indeed Professor Caprini means so much to us, and I think to all the vascular and not only ward. Indeed, Professor Caprini is working splendidly in expanding the score in many different specialties with a dedicated DDF committee. I really enjoyed this sentence he once told on stage: never kill a friend, never treat a stranger. It will be him explaining to you in the final comment maybe what it really means. We know how much it means, Professor Caprini, to us, so we ask him to give the final remarks of the last great webinar.
Thank you very much to everyone, and I would like to be able to share my screen. And first of all, regarding never treat a stranger, never kill a friend. This came to me. I have a very special dedication to my dear friend in Maine, who was an academic dentist and actually suffered an osteosarcoma of the hip and had to have a hemipelvectomy and lost one of his legs. A dear, dear man. He's doing very well, but I was asking, we were discussing things. We used to walk together when in Maine, and he said to tell me about your risk assessment, and I explained some things to him. And then he said to me, well, he said, Joe, he said, it's very simple. Why don't you think about it in these terms? When you meet somebody, they're strangers. So interrogate them with a thorough investigation so that now you know as much about them as you would about your average friend. And then, of course, you would never treat somebody without doing that. So you'd never treat a stranger. And of course, once you found out all of their risk factors, you would protect them. So that means you would never kill a friend. And that's what it really is all about. And I'm very indebted to him for giving that insight. And I'm also indebted to be here with all of you from around the world. As I said, I'm not just exchanging social insincerities. I have learned a great deal from all of you today, from all parts of the world. And if I skip and don't mention something here with someone, I apologize. One of the last interesting things I thought was Professor Cavizzi talking about the post-exercise pressure measurements. I think that's a really, really important observation. One of many, many today. And the other one, just because I didn't specifically put it in here, is that it's very important with these patients, just like it is with any venous insufficiency patients, to make sure that surface venous insufficiency, perforator insufficiency, is treated with the appropriate modalities as a part of the overall program. So that having been said, again, it's a great pleasure to be here. And first of all, I'd like to talk about Dr. McMurray's lecture, which again, in 8 minutes, it's unbelievable the amount of data he presented and how important that is. And we start out with these classical criteria that have been mentioned for the US, for Europe, and Dr. Good just mentioned them in China. And what I think is important is that the numbers don't mean much by themselves. There's a lot more to that than just the numbers, and we'll come back to that. The other thing that's important is the realization, and it's been brought out, that over 20% and maybe even higher than that, patients do have chronic venous disease. Now, we also know that this is very interesting. It was pointed out by him that the higher SEEP score, the higher the benefit from compression, and the lower ABI, the higher benefit from compression. And it's really interesting because in this study, they pointed out that if they applied the classic numerical criteria, 13% of the patients who obtained greater benefits would not have utilized GCS on the basis of the ABI below 0.5. Now, another thing that's that's come up, which is really important, and we hear it over and over. The one thing that I would like to emphasize in my final remarks is, as everybody talks about compression and PAD, it has to be divided into those that the type of compression. That's just as important as the compression. And here we see one of the landmark publications by Giovanni Mosti involving the use of short stretch compression in order to improve arterial perfusion. And he talks about a compression pressure of up to 40 millimeters of mercury. And in actual fact, and we'll come back to this later with some of my pico press measurements, that when you apply short stretch compression, you have to make sure that the applied pressure is less than the perfusion pressure in the leg. And as long as the resting pressure of a short stretch, not long stretch, but a short stretch compression is less than the perfusion pressure, then you can be safe in using that in your patients. You can't be so sure with elastic, of course. And he came up with some very important conclusions, all in 8 minutes, and I won't repeat them here, but I think he did a wonderful job for us. And for a young person to have that much comprehension about this disease is very important. And I think this emphasizes another point that Giovanni Giacchini, Sergio Giacchini and Oscar Bottini have really emphasized, is getting to young people, getting to people at an early stage and teaching them all of these things, so that this great project has been a fabulous thing. Now, Fabrizio presented some wonderful data on this topic. And again, he comes back and he emphasized the fact that showed the current ABI of 0.8 is considered an exclusion, but then he goes on much further and goes into a nice discussion about the value of compression stockings. Now, these low pressure compression stockings are important for mild PAD, and that's been shown over and over. And I would just like to emphasize that these are mild PAD. And now this slide, when I saw this last week, I was shocked, because a low resting pressure and a high working pressure is the sine qua non of short stretch compression, and not of a class 2 compression band, of a class 1 or 2 stocking. And so I reached out to Hugo immediately, my mentor to the God. And I said, Hugo, tell me about this. And Hugo also said they didn't really measure this. He doesn't understand how they come up with these numbers. And so we have no explanation. But I would just hasten to add that this is a very misleading number. And then we get back to Giovanni again and the short stretch compression, and of course the legendary Hugo, and emphasizing short stretch compression is very, very important for mixed ulceration, and of course in patients with CVI and PAD. Now, leg compression. And I did many clinics when I was younger. One of the things I really missed was going to another city and having physicians come in and supervise them wrapping their legs. And then in all cases, we had pressure transducers underneath to see how well they did. And this study, which was so nicely presented, is emblematic of the difficulties that even trained personnel have in putting on the proper bandage pressure. So I had a trick that I used in my vascular surgery practice, which seemed to work very well. So we just wrap these bandages on with a certain technique that Hugo has taught us, to just wrap them on with a tiny bit of pull with each stretch and with a pressure measurement underneath. And then I would have them put on 2 and 3 bandages, one over the top of one another, until when they felt the leg, it felt like a blown up football or basketball. And I was able to correlate that tension with the hands in our group of people that put on these bandages with a compression, a resting compression of about 40 to 50 millimeters of mercury. And that's not the total answer. And I would just like to say that this is a very important problem. As much as I rave about short stretch compression, as Hugo said, the pressure is in the hands of the applier, and it's still a difficult problem. And another study that was presented, and And this is where we get into this progressive compression. This is an extremely important concept, and I'm just so happy to see people from all over the world acknowledging this. And you know, this isn't rocket science, is it? Where is most of the blood in the lower leg, in the veins? It's where there are the biggest veins with the most blood. That's the calf, the proximal calf. And so by compressing that proximal calf, you're pushing more of that blood out of the leg, and putting more pressure down on the ankle, which is just tendons and bones, doesn't really make any sense. And thanks to Hugo and Giovanni, they've paved the way for this. And now it's time for us to put pressure on the companies to start producing these products. It's very, very important. And now it's a totally new world, because now we have mobile compression devices, multiple mobile compression devices. And that's going to be the answer, because this is very important in these patients. And you know the value of compression, of a high compression in failed bypass grafts and in people who can't be revascularized. What happens is that high pulsatile pressure removes quickly so much blood from the leg that it lowers the capillary pressure at the venous end, and that reduces the resistance in the capillary and allows increased perfusion of the arterial blood. And so this is a very important concept. And here's another one. This isn't rocket science either. The reason that this hasn't been done, I think, is because it's more expensive to produce a short stretch complex stocking product. And maybe that would be harder to put on and off, but this is another area of future research. So this talk contained a lot of really valuable information and thought-provoking information. Now we come to Professor Kabisi, who has made incredible contributions, and I probably won't do justice to everything he said. And I just like to highlight here how important he was talking about the, shown on this slide, the risk of complications with, and especially with the microangiopathy that's present in diabetes. And and I think from my dear colleague from Thailand, and I'm again indebted to the Thai people for all the work they've done in terms of the risk assessment, but including one very special study in hip fracture patients that needs to be repeated. In any event, it illustrates the importance of gathering people from all over the world together and pooling your knowledge. But the idea, and he brought this up too, is that you can't just rely on the compression on the ABI, because some of these vessels in diabetics are non-compressible. And so you get a falsely high reading. And so that post-exercise postulate that was put forward, I think, is an extremely important one to sort out this issue. And now we get back to lower compression products in mild edema, in mild CVI, and that's fine. And again, this interesting study, I'd like to point out, comparing the two classes of lower compression stockings. And remember what's on this slide when the patient's legs are elevated or when the patient was standing. This is a sort of a little picture that shows you the absence of a good standing stiffness index in patients with elastic compression. And he also pointed out to us the importance of, and again, I've just sort of summarized this in another way, increasing the tissue perfusion at the microcirculation as a result of lowering the end capillary venous pressure by removing blood from the leg. And there's also other factors like VEGF and TNF factors and so forth that are affected by this. And then we come to Dr. Chi, and of course he presented to us this I thought was a really incredible slide, because this was 2006. And you know what? With all of this, we can fly airplanes and we can drive cars automatically with computers, but we still haven't figured this out. You know what the answer is? It's money. And here are the normal pressure transducers, and I've used the Pico press for a long time and had great success with that. But I'd like to point out in the United States, and I hope they make this available for the rest of the world, the Juzo device is actually a pretty good device. And it's very simple, it's very inexpensive, it's easy to use. And the other thing is, don't forget, and Dr. Chi pointed this out too, is it's not the absolute pressure, it's the relative pressures that are more important. And as much as this is nice and these are nice, it's not the end all. But remember now, we need a dose for compression. We have a dose for all the anticoagulants, don't we? You would never think of giving an anticoagulant without a dose. Why don't we have a dose of compression? And until we get more information, measuring this with a pressure sensitive device, I think is right now the way to go. He talked about some future issues. The piezoresistive sensor is a fascinating concept. And he also showed the flaws with the current transducers and with the current pressures.
وبعدين
Khaled, please control mic. Khaled.
Yeah, with the current pressure sensors. Now, the big, if you will, excuse the expression, the 10-ton elephant in the room of the Chi presentation was not so much about pressure sensors, but about the lack of compliance. And this is our big issue. So many times I see patients and you give them compression, they come back later and say, well, my legs are swollen. My legs are still swelling. Well, where's your compression devices? Where are your stockings? I don't know. The dog ate them. They lost them. They wore out and so forth. And compliance is a really big issue. And that in the SOX trial was one of the key things that invalidated that trial in the eyes of many of us. And that is that 55% of the patients use stockings more than 3 days a week. And then the other thing, and I hate to keep after the SOX trial, but I'm in my 8th decade. I have a mild swelling and I've had an injury to one leg and so forth. But anyway, I need to use adequate compression therapy. And most of the time that's with a good stocking, but sometimes I use a Velcro or strap device. But the thing is, to tell me that I couldn't tell the difference between a sham stocking and a 30 to 40 stocking on my leg is just a fantasy. Any of you who have ever worn these stockings know that. I don't get that. And again, some very powerful take-home points. I won't repeat myself with that. Now, I'd just like to give you some of my own personal comments. And again, as I said, and I really believe this, that I feel like a much richer person after being a part of this presentation from hearing from all of the opinions from all of you. If you take a short stretch and a long stretch, an ACE bandage and a cotton bandage and a non-stretch bandage, and you grab them at the same point and stretch, you can see the difference. And so elastic compression, what are its characteristics? A high resting pressure, which makes it uncomfortable over time. A low ambulatory pressure, because as the leg swells, the bandage gives way and the edema increases until it finally gets to such a point that it just it exceeds the stretch capability of the stretchy garment, and then you have a tourniquet effect. And the standing stiffness index or the static stiffness index, I always refer both ways to those terms, between lying and standing, is less than 10. And here's a Pico press demonstration. This happens to be with a graduated stocking that after surgery, the so-called surgical hose. You can see there's no difference between lying, standing, exercise, and recovery. Now, if we go to a class 2 compression stocking, and there's many examples of this, we do have a difference between between the lying and the standing pressure. And that's one of the reasons that this works very nicely in mild disease. There's no question about it, and I'm not discouraging its use, but it has to be used in the appropriate patients. Again, compressive compression therapy has been shown to be very important, and that Giovanni again and Hugo have written the book on that. And if you take a look at it, the supine interface pressure with a graduated stocking compared to the middle level to the proximal level of the calf, B1 is the tendinous and muscular junction. C is in the big part of the calf. And you can see with graduated compression, of course, the amount of pressure, the interface pressure in the calf where all the blood flow is and all the veins are is less. And it's just the opposite with the progressive. And the interface pressure, again here, you can see is similarly between the graduated compression and progressive compression. And so, and I learned this from Federluri. I thought this was a very insightful comment. analysis he made. And you know, the SOX trial used sham stockings, so-called sham stockings. But in effect, they weren't. They were progressive compression stockings, where the pressure was higher in the calf than it was in the ankle. Why? So the stocking wouldn't fall down. And so what we can say about this, interpreting the SOX trial, is a low pressure anti-graduated stocking prevent PTS after a first proximal DVT at a similar rate compared to 30 to 40 millimeter graduated compression stockings. That's the first thing. The second thing I want to say about this is that unfortunately that this got into the guidelines as a dictum, saying that they don't post that graduated compression stockings, or in this case, both types of stockings, don't prevent the PTS. Well, the PTS in this study was around 15%. We know that up to 50% of people that have a DVT can get PTS. So this really doesn't help us. But since it got into the guideline now, people are not using compression stockings when they get an acute DVT, and it's really a terrible problem because, and again, Hugo really showed us that in those first 2 weeks after an acute DVT, the importance of adequate compression is vital to the long-term success of that patient. And of course, nobody in this trial got stockings for less than 2 weeks. Well, what about this giraffe that you see behind me? Most people are unaware that giraffes have venous pressures of 250 millimeters at their ankles, 3 times that of the humans. However, giraffes do not suffer from lymphedema or venous disorders, and physiologists have discovered that the answer is in the skin. Giraffe skin is inelastic, so it does not stretch. As the giraffe leg muscles contract, the veins in the legs are squeezed and the blood is forced all the way back up that great distance to the heart. And thus, giraffes are not susceptible to problems like lymphedema and venous disease, even though they may be on their feet 24 hours a day. Remember the giraffe. The characteristics of short stretch compression are it's low pressure at rest, it's very comfortable, and there's a high walking pressure, which decreases edema, and a great difference between lying and standing pressures and walking. Now, one of the most important concepts that I ever learned from anybody was from Hugo Parsch. When I would come in and say something to him very dogmatically, like is my style, he would say, Joe, remember, there are many roads to Rome. And so just so with this compression, an Una's boot, a Jello-Cast boot, is a short stretch compression. Short stretch bandages, of course, Comperlon, Rosadol, and the like. Velcro devices, and now we have another strap device, but also elastic bandages, the so-called 4-layer wrap. They're all elastic, but when you put 4 layers one over the other, it becomes more inelastic. And this is the bandage that we use in our clinic, and we put on multiple short stretch bandages, and I use a Coban cover over that. And I can tell you that we had to leave these bandages on for a week because in my clinic, we weren't allowed to see the patients any more often. There was no time to do that. So they all had my phone numbers, and I was waiting for them to call me up after this. But using this dictum of measuring the pressure in the legs and using the applier's fingers to make sure that the tension on the tension was like a blown up football, we had very good success with this. And here we have an Una's boot, short stretch bandages, Coban cover, and look at the resting pressure. It's less than 60. And somebody would look at this, oh my God, 120 millimeters with PAD, you can't do that. Well, wait a minute. If the perfusion pressure in the leg is greater than the pressure of the resting pressure of the inelastic bandage, then it's safe. And what we found is, and this is the same type of pressure curve that you use with IPC and failed bypass grafts, and the spike that it goes up and the undulations, the fluctuations in pressure that occur with, it's like almost a pneumatic compression device in a sense, as the patient walks and the calf pumps against it. Giovanni has taught us that this simulates valve closure. And so valves that are incompetent sort of temporarily open and close with that. Now, what's not shown on this graph, if I were to continue this out, this pressure would begin to drop, because as the short stretch bandage drives edema out of the leg, then the pressure drops and the bandage loosens. That's why we needed a co-band cover, and that's why it's preferable to use the Velcro devices, because as they loosen, then you can just tighten them. And these are very nice because they're easy to use, they're adjustable, you can measure the pressures. Now, unfortunately, there's an expense issue from around the world, and my heart goes out to people. One of the great pleasures I had when I went to do these conferences, for example, at the VEITH and for example, at the European Vascular Course, I would contact all the Velcro manufacturers and I'd get them to send me boxes of these devices. And I would take them to these clinics in various parts of the world and summarily hand them out to everybody that was interested and participated in my class, just to try to get them out there and to try to encourage some use. And at one point, I did have, I believe that there's a person that I contacted and used to work with that was a representative in 93 countries for one of the companies. And I think that they're starting to make those more available. And I think this has really been a great secret of mine and a great secret in the practice, because even in people who can wear stockings, 20% of them have trouble putting them on or off, and these devices are ideal. They provide a low resting pressure, they're easy to tighten, and they can be used for most of the pressure, most patients, as long as the resting pressure is less than the systolic pressure. And here's a typical curve. This was on my own leg. And you can see that, again, the pulsatile nature of this, especially when the patients are walking and standing. So it's a very, very important device. So in conclusion, understand the differences between short and long stretch devices, including the shortcomings of elastic stockings and the value of Velcro compression in patients with mixed arterial and venous disease. Employ short stretch products rather than elastic compression in PAD patients with severe disease and severe venous insufficiency, and also with ulcers. Velcro compression is ideal for treating reperfusion edema following femoral popliteal bypass. I can't tell you how many of these patients I've seen come in, and we already discussed this earlier, even from some of my colleagues in the vascular surgery division, of which I'm a part, still putting ACE bandages on these people because they're afraid to put heavier compression on them. Velcro compression is ideal for this. And if the patient has discomfort, they loosen the device, but often the devices fall down because the leg will shrink and the edema will decrease, and they can reapply them. And don't forget, the big problem, the 10-ton elephant, as I like to say, in reperfusion edema is if that wound gets infected, that graft is going to go down. So this is a really critical issue. And then explore the use of pneumatic compression devices for severe PAD, especially when ulcers are present and revascularization not possible. Now, I would just like to stop sharing my screen a minute and give you the final conclusion, which is for Joe Caprini. And that is to please listen to all of the other wonderful people from all over the world, from many races, religions, cultures, and languages, because you all have something very important to teach me and all the rest of us. And finally, we somehow have to keep this group together going forward to continue to improve care around the world, which is, I think, is our total mission. And again, to Giovanni and Oscar, Mazel Tov, congratulations. I can't tell you how wonderful it is to be a part of this entire initiative. Thank you very much.
Thank you so much, Joe. Thank you so much, of course, also to Oscar and Willie. And thank you so much for allowing all of us to stand up on the shoulders of giants like you, and to make me feel so proud of wearing this T-shirt representing your values. We conclude inviting everybody to visit the V-Learning platform, where you can find all the recorded material we have produced with these live webinars. So the educational content will remain there in the different languages. One last word also from the pillars, of course, of the WIN Foundation. So Professor Bottini and Professor Che, without whom nothing would have been possible.
Thank you for participating in this educational proposal. See you again next Saturday. Thank you.
William?
Thank you all. Although this is the last session of GREAT, I'm pretty sure that we'll see each other again. Thank you.
Thank you so much, Willie. And indeed, I take this chance to invite everybody to send abstracts to the event that Oscar will manage together with many friends from Latin America in Buenos Aires next September, when the board will gather together. Thank you so much to Mehdi once again for having allowed us to explore this great road involving in particular residents and the synergy with the arterial disease world. We always look for synergy in the WIN Foundation based on evidence-based data. So the next weekend, we will focus on a synergy with the general practitioners for advancing in evidence-based venous and lymphatic practice. So if you are interested in general practitioner corporations, this will be the 4x4 initiative with 4 modules of 4 talks each starting next week. We close this great experience with a sentence that I really appreciate as a quote: "The greatest good you can do for another is not just to share your riches, but to reveal to him," and I like to add also her, "his or her own." So I deeply thank the giants who allowed the residents to get on board and the new generations to get on board. It has been truly a wonderful group of new generations and top mentors and great faculty members. We all thank so much for their involvement in breaking down the wall that is usually separating the, I would like to say, endothelial wall of the arterial and venous wall. Of course, another wall we want to break is the one of evidence-based data not to use, meaning the fake news we can find around the world. We know per publications that up to 40% of the medical websites are still including fake news. For this, I deeply thank the more than 70 societies from all around the world involved in this group effort. I remind you that you can report eventually encountered fake news in the venous lymphatic ward in this website. They will contribute to the creation of a multilingual consensus document that will be presented during the Health Week in the once-in-a-lifetime opportunity of the Universal Expo in the spectacular Dubai, where we will all be able to find each other again, finally, for a social moment, finally properly dressed, like for the T-shirt of Professor Caprini, like it was in this nice gathering of the Winter 2019 in Cortina. Until next time, thank you so much all for this great teamwork and great experience. Ciao.
Thank you.
Ciao.
Ciao.
Thanks, Sergio.